I'd like to introduce you today. This is going to be a 71-year-old female. She has a long-standing history of rotator cuff tear arthropathy, which, as you all know, is osteoarthritis in the shoulder developing as a result of severe chronic rotator cuff tears, where with proximal humeral migration, where the humeral head articulates not only on the glenoid bone on bone, but in her particular case, it migrates superiorly and articulates with the undersurface of the acromion and the undersurface of the AC joint, actually eroding away the superior aspect of the humeral head, the superior aspect of the glenoid fossa, and cavitating the undersurface of the acromion and wearing through the AC joint. Now, she's had her pain in both shoulders, the same condition, for approximately 10 years. Became quite severe 2 years ago. At that time, she had less deformity than she currently has. She had persisting pain, so that in March of this year, we actually did a reverse shoulder arthroplasty on her left shoulder, which was the more symptomatic of the two. And today, we're back here in January 1st, some 9 months later, doing the opposite side because her pain relief on the first side has been so complete. She still has some residual weakness, as would be expected when you have no rotator cuff muscles to rotate and elevate the arm. But her pain relief has been incredible, and she's very, very happy and satisfied with the outcome on her first left shoulder. The examination in the office shows very limited motion. She can only actively elevate in flexion to approximately 65 degrees and abduction to approximately 35 degrees. Her external rotation at the side is a -5 degrees. In abduction, she's got a positive hornblower sign. She has an extensor leg with a springback sign at the side. Internal rotation strength is slightly better. She's got obviously positive Napoleons in belly press, but she does have some internal rotation strength. I'd like to review the x-rays with you now. So this is the patient's AP x-ray of her shoulder 1 year ago, November 2006. At that time, we can already see the bone-on-bone glenohumeral articulation, proximal humeral migration, and secondary changes of the superior humeral head with osteophyte formation and early scalloping on the undersurface of the acromion. I want to show you the axillary view, where here is posterior glenoid, anterior glenoid, and we can see that she's bone on bone, and she's actually eroding down to the base of the coracoid, which can be seen right in this area. 1 year later, we can see there's been significant erosion of the glenoid superior with medial erosion right into the base of the coracoid, which is in this location. You can see bone fragmentation at the inferior glenoid with a loose fragment here, and significant medial abutment resulting in scalloping and notching of the inferior medial humeral neck, something that we very seldom see in the absence of a reverse prosthesis. Superiorly, she's bone on bone against the acromion. She's eroded through the distal clavicle in this location. And for comparison purposes, again, this is how she looked a year ago. Minimal, if any, scalloping medially, and now this last month, quite significant changes right there. Her axillary view taken last month again shows the same, where she's bone on bone, humeral glenoid articulation, bone fragmentation and osteophyte formation in the posterior glenoid rim. This is a bone fragment anteriorly, and she's eroded right into the base of the coracoid process. Preoperative radiographic evaluation also includes a CT scan to more adequately show us the bony anatomy of what we're dealing with. We can see just how clearly she's developed cystic degeneration of the humeral head, bone fragment in the back in the capsule that we'll have to remove at the time of surgery. And this is the base of the coracoid, and she's eroded right down into the base of the coracoid. If we come down just one row on the panel, you can see measurements where I've measured her glenoid retroversion, which still measures only a -5 degrees, so there's been no posterior or anterior erosion. It's all been central in the superior half of the glenoid, because the inferior glenoid looks relatively well preserved, with the exception of the cystic degeneration that you can see. Just for the sake of demonstrating what her procedure will look like when it's completed, this is her radiograph of her left shoulder that we did in March of this year. And you can see the reverse endoprosthesis with the humeral component, the humeral glenoid socket, and then the glenoid glenosphere, which screws into the scapula with locking 5.0mm peripheral screws, a central screw post, which is 6.5 millimeters, and then the glenosphere with which the humeral component articulates.